Topic for today's class will be uh, today we're going to discuss about infectious arthritis, and this topic is important because so many cases that we see in our OPD or in our inpatient are mostly because of infection in the joint rather than inflammatory conditions. I am Dr. Devender Bairwa. I did my DM from Chipper in immunology, and previously I did my MD medicine in AIDS and MBBS from MAMC. So we will be discussing this topic, this class under following headings. First, we will try to provide some stimulation to you so that you can think about possibilities of these different infectious arthritis. Then we will see about approach to patient of infectious arthritis briefly. Then we will discuss about acute bacterial arthritis, spirochetal arthritis. Acute bacterial arthritis will also contain gonococcal arthritis. Then we will discuss about mycobacterial arthritis, fungal arthritis, viral arthritis, parasitic arthritis, and then we will see about post-infectious arthritis, that is also known as reactive arthritis. And in the last, we will see about prosthetic joint infections. So let's see some questions and let's see how these different infectious arthritis can present to us in clinical practice. So let's say first question is musculoskeletal manifestations of syphilis are generally most commonly seen in whether primary syphilis, B secondary syphilis, C tertiary syphilis, or congenital syphilis. Next question is a nursing class teacher, she's 35 female. After being exposed to some flu-like illness in the class, she developed some inflammatory additive arthritis with features of anemia within 2 weeks of exposure. Blood workup showed positive ANA, positive rheumatoid factor, as well as antigen antibody. She is most possibly having A. SLE, B. Undifferentiated connective tissue disease, C. rheumatoid arthritis, or D. parvovirus B19 infection. Next question. Acute chikungunya fever, most common joint that is seem to be involved in our Indian population is A. wrist, B. knee, C. ankle, D. MCP. A follow-up patient in ART clinic having severe reactive arthritis, not being controlled with NSAIDs and sulfasalazine. In this patient, correct statement or statements regarding further management includes A. HIV patients have higher sulfur drug allergy. B. TNF inhibitor should not be given in HIV patients. C. Viral load and CD4 count should be checked before planning biological therapy in this patient. Or D. HIV-associated reactive arthritis is milder than the general form of reactive arthritis. Next question. 40 years old known rheumatoid arthritis patient with history of right knee joint prosthesis 2 years ago is planned now for right third molar extension. It means a patient of RA with history of some joint replacement in the past now is planned for some dental extraction. Incorrect statements in this case. A. RA patients have higher chance of septic arthritis. B. Prophylactic antibiotics therapy is not needed in this case. C. Prosthetic joint infection always necessitates removal of prosthesis. Or D. Dental procedure predisposes to increased chance of prosthetic joint infection. So as we discuss our presentation, we will get to know answers about these questions. So let's focus on that. So approach to patient. So why infectious arthritis is so important? Because suppose if the joint is infected and if you do not treat that infection within short span of time, then because of infection, what can happen? There will be so much proteases, neutrophils, so much inflammatory infiltrate that it will lead to rapid degradation of cartilage and joint damage will be there. That is why all patients suspected of infectious arthritis should have a prompt diagnosis and management is must. So generally, if we see clinically, we can divide into some types. There can be either acute bacterial infection. Generally, acute bacterial infection will present in the form of monoarthritis or rarely oligoarthritis. This oligoarthritis picture is more common in patients who are either having immunosuppression or some underlying CDD like RA patients. Then there can be presentation in the form of subacute or chronic monoarthritis or oligoarthritis. In these cases, generally, these organisms are mycobacterial infections like TB, or there can be fungal infection because these are slow indolent infections, or there can be episodic inflammation. This is generally seen in case of syphilis or Lyme disease, or in case of reactive arthritis. Also, there can be acute polyarticular inflammation that can be because of infection per se or because of immune complex deposition and a response towards infection. And these These acute polyarterial inflammation example include endocarditis, acute rheumatic fever, disseminated nasal infection, acute hepatitis, and many viral diseases. So this table is from Harrison. This table is showing some commoner causes of arthritis syndrome in our patients. So generally, acute monoarticular arthritis, as we can see in this table, most of these organisms are generally, if you see, infective forms like bacteria, staph, strep, gram-negative bacilli, Neisseria, fungal candida, or there are other causes they have mentioned which are not non-infective should be considered when the possibility of infection is low. Then, in case of chronic monoarterial arthritis, generally these are either fungal infections or these are generally your mycobacterial infections. In case of polyarterial arthritis, they also can have bacteria or fungal or virus depending on underlying conditions. Mostly, patient will be having some kind of immunosuppression therapy going on, or they'll be having underlying CTD. In our setting, most common we see this polyarterial infection in our RA patients. So coming to further approach, so remember one thing, whenever a patient comes to you with monoarthritis presentation, single joint involvement, if there is joint pain and joint swelling, if there is possibility of aspirating fluid, then this is the standard investigation. Any patient presenting with acute monoarthritis with tenderness, swelling, and some effusion, always go for a synovial fluid aspiration and analysis. So generally, when we aspirate fluid, we look for its gross morphology. Then we look for cell count. We also look for cultures. Uh, Remember one rule that in case of synovial fluid, we never go for estimation of glucose levels, protein levels, LDH levels because all these are actually elevated non-specifically in most of the conditions. So see this flow chart. Suppose if you have like aspirated fluid from one joint suspected of infectious arthritis, then you can go with the cell count first. In general, the number of cells in a synovial fluid, normal synovial fluid is less than 180 cells per m. If cells are increased, there can be cells can be either mildly increased or more or severely increased. So suppose if cell count is more than 1,000 and between 30,000, and if suppose there is if there is no possibility of hemorrhage, there is no bleeding in the joint, then you look for presence of any organism. So what you can do, you can make a smear of that fluid on gram stain, and you can quickly look for presence of any uh, microbes. Or if suppose there is any organism or there is presence of leukocytes more than 90% and there are polymorph cells more than 90%, then possibility of infective arthritis is there. So these leukocytes are nothing but neutrophils which have like consumed lots of immune complexes. These are known as leukocytes, most commonly seen in either infection or seen in case of RA patients. So in our setting, when patients have that much high count, there can be a coexisting crystallopathy or there can be crystal itself. So we always send our patients fluid for analysis of crystal as well as for infective organisms. So then other causes are there. Suppose if there are presence of your cytophagocytic mononuclear cells, then we think of possibility of spondyloarthritis. If there is features of more leukocytes, more than 50% of polymorphs, is there is present of other specific cells, then we should look for arthritis. In case of viral arthritis, we can see that most of the cells will be mostly monocytes. More than 80% cells will be monocytes. And suppose if there is presence of some LE cells with the lymphocyte, mostly it is SLE patient, then we can look for the presence of lymphocyte count. Lymphocyte count is increased in case of mycobacterial infection, SLE, sometimes in RA and lymphocytic arthritis. So suppose if none of these things are there, then mostly we go with the diagnosis of primary inflammatory arthropathy. Suppose if count is very high, like count is more than 30,000. In such cases, mostly there are two causes that you have to see. One thing will be your infection, other thing will be your presence of crystals. So septic arthritis generally will have count somewhere around 50,000, 80,000, like that count will be there. And as I already told you, no matter what, you always send patient sample for crystal as well as presence of these infective organisms. So depending on that, we can also divide whether crystal is there or septic arthritis is there. So in our septic arthritis patient, what we will see, grossly when you aspirate the fluid, you will see that it is turbid. There will be loss of viscosity of that fluid because what happens generally, this fluid is viscous because of presence of hyaluronic acid. Once there is infection, Infection leads to activation of multiple proteases in that fluid, and because of that proteases, this hyaluronic acid is broken down, and once it is broken down, that viscosity goes down. So loss of viscosity also favors your infection. And then we do a direct gram stain smear we can do, and after that we can send it for culture. Apart from this, what we can do, we can also look for presence of nucleic acid amplification based techniques. So these Na based techniques actually increases sensitivity of capturing your infective organisms, specifically in case of gonococcal arthritis. Now remember what happens, gonococcal arthritis when happens, and when gonococci is there in the joint. So generally, gonococci, it is difficult to take a smear in a good way. Other thing is that when you transport that swab, it has to be transported in a special media, and sometimes that media is not available, or the technique of sending is not proper. That's why the culture rate is actually less positive in case of gonococci arthritis, and in that particular case, your nucleic acid amplification based technique is more better. So these all tests can be done when you are dealing with a patient of infectious arthritis. Coming to acute bacterial arthritis, so understand this first. In general, joint is sterile. Joint will not have any kind of organism to that. But the problem is, suppose if there is any kind of infection in the body, let's say pneumonia is there, or UTI is there, or let's say there's infection in gut. So what can happen, because these capillaries in the synovial lining, they don't have any limiting basement membrane. So what happens once if there is hemolytic spread, if there is bacteremia in the blood, bacteria once reaches to this thing, your joint, then it can stay there. Or there are other routes. So most common route of infection is hematologous route that happens in this case. Apart from that, there can be dissemination from contiguous osteomyelitis. There can be spread from an ingestion soft tissue infection, or sometimes there will be history of some therapeutic or diagnostic technique like arthroscopy has been done, or intra-articular injection has been done. That will be there, or then there can be directly a penetrating trauma or puncture trauma to our joint. So in all these ways, what will happen? Your bacteria will enter the synovial cavity. So in case of hematologous infection, bacteria escape from synovial capillaries because there is no limiting basement membrane. And within hours, what will happen? Because now bacteria has reached their neutrophilic infiltration of synovium will occur. Then because of this neutrophilic infiltration, there will be release of so much of these proteases and other enzymes which can lead to degradation of cartilage. So degradation of cartilage, it starts as soon as like less than 48 hours. And the various reasons why this degradation occurs, one thing is because of that this increased intra-articular pressure, because of lots of fluid is forming there because of leakage. Then there will be release of proteases and cytokines from chondrocytes and some macrophages, and there will be invasion of the cartilage by bacterial inflammatory cells. So what happens if you will take a section of an acute septic arthritis joint? You will be able to see the deposition of these bacteria over the cartilage as well as site. So this is the reason you can see that if within 48 hours, if there is so much damage to joint, this is so much necessary to treat these patients as early as possible. Otherwise, joint can be at risk. So histology, if we see, generally we can see these bacterial lining synovium and cartilage. There will be formation of small abscesses that can extend into synovium or cartilage. And in more severe cases, you can also see these abscesses extending to the subchondral bone. And because of the reactionary response, there will be synovial proliferation. And there will be formation of pannus over the cartilage. So this pannus is nothing but pannus is a inflammatory mass which is composed of this inflamed synovium along with presence of infiltrated cells like neutrophils. There can be neutrophils, lymphocyte, plasma cells, and all these things will be there along with fibrin. It will form a pannus. Then, because of this local procoagulant state, there will be thrombosis of inflamed synovial vessels. Some bacterial factors which promote this septic arthritis include surface associated adhesin in staph. Yes, because this surface associated adhesin will help the staph aureus to bind to cartilage, or there can be production of various kind of endotoxins by these mostly gram-negative bacilli, which can lead to breakdown of the cartilage. So all these will favor the septic arthritis. Coming to microbiology means what are the common causes of septic arthritis in different age group. If we see in case of infants, mostly the cases of septic arthritis in infants are because of group B streptococci, or there will be cases of gram-negative enteric bacilli or staph aureus. So there is no data which is more common than the other, but all these three are mentioned in Harrison. Then coming to children less than 5 years of age, in this age group, this is Staph aureus, which is common, along with Streptococcus pyogenes and Kingella kingi, they are telling. Earlier, when there was no vaccination for hip, then at that time, Haemophilus influenza B was also a common cause. But now, because after vaccination, it has reduced. Coming to young adults and adolescents, in young adults and adolescents, most common cause of septic arthritis is disease gonorrhea, that is leading to gonococcal arthritis because of sexual activities. Then, in case of adults, most common the cause is Staph aureus and followed by gram-negative bacilli. Then pneumococci is there. Beta hemolytic streptococci group A, group B, both are there. In case of older population and people with having some comorbid illness, even type C, type G, and type F has also been seen. So these are the causes as far as age group is concerned. Now, if we see other association like after surgical procedures, most of the cases are because of Staph aureus. In case of implantation of prosthetic joint or arthroscopy, these are the cases where you can find the cause of arthritis is Coagulus negative staphylococci. In general, in the native joint, Coagulus negative staphylococci generally does not present in case of septic arthritis, but whenever there is a history of intervention with prosthetic joint arthroscopy, then this can be a common culprit. In case of human bites, in case of decubital ulcers, interabdominal abscess, when these ulcers and abscess, when they reach to the nearby joint, in such cases, you can find anaerobic organism, often in association with aerobic or fatality bacteria. Multiple bacteria can be there. In traumatic injuries with extensive contamination, if a joint is ruptured, then in those cases, mostly really polymicrobial infection. In case of bite and scratches from cats and other animals, mostly Pasteurella multocida or Bartonella hensley, these can be found in these joints. And in human bite, cases of Echinella cordis have been reported. Suppose if there is a penetration of sharp object through a shoe or like this, then in such cases, Pseudomonas aeruginosa can be there. So coming to risk factor for development of septic arthritis, in general, if you see the prevalence of septic arthritis not very high, but in some age group and in some diseases, there is high rate of your septic arthritis development. In our setting, we see most commonly in RA patient. Apart from that, presence of prosthetic joints or history of a recent joint surgery, low social status, advanced age like more than 80 years of age, IV drug abusers, then alcoholism and hemoglobinopathy. In alcoholism and hemoglobinopathy, mostly Pseudomonas is the culprit. In cases of diabetes, intraarterial injection history, if there is a skin infection or critical near to joint, after biological therapy like TNF inhibitors or other biologicals, and as well as in PID cases. It means primary immunodeficiency cases. In primary immunodeficiency cases, mycoplasma can be there, and mycoplasma leads to a severe deforming arthritis in these patients. So these are the risk factors of development of septic arthritis. Let's see how these patients of septic arthritis they present. So generally, in 90% of cases, septic arthritis will be in only single joint. And most common joint that we see in our clinics is knee, followed by hip, followed by shoulder, and wrist and elbow. And these small joints will generally not be involved unless there is a risk factor like bite to the small joints or there's the inoculation uh, of pathogens to these joints. Otherwise, generally, it is the large joint monoarticular presentation. In case of IV drug users, there can be involvement of spine as well as sacroiliac joint and sternocleidomastoid joint. And in our RA patient, we can see polyarterial infection. This figure is from Harrison, and you can see there is swelling and fluctuant swelling is visible over left sternocleidomastoid joint, and this is a figure from taken from one IV drug patient. Okay, so what happens generally, they will have moderate to severe pain that will be uniform around the joint. Uniform pain around the joint signifies that the pathology is the joint and not in some periarticular structure. Then there can be joint diffusion. Joint diffusion is visible in superficial joint like knee joint. In deep joint like hip and shoulder, it can be missed. There can be muscle spasm because of pain there. There can be decreased range of motion of the joint. And there can be fever. Fever can be very high also, like 101 to 102 degree Fahrenheit. And whenever there is septic arthritis, you have to always look for the extra articular foci. As already we discussed that in acute septic arthritis, the most common mode of spread is hematogenous. It means somewhere in the body other than joint, there will be some infection which has reached to your joint because of bacteria. So generally there will be a boil or pneumonia or GI infection, or there can be UTI. So these kind of infections will be there in these patients. If you will see their patients' blood workup, they will have neutrophilic leukocytosis with a left chip. There will be rare GSR, rare CRP. Now we are telling that fever is there, but you remember that fever may not be there always. Sometimes fever may be absent, specifically in cases of rheumatoid arthritis, patients with hepatic or insufficiency, or if patient is on immunosuppressive therapy like steroids are going on. In such patients, there can be still no fever. So absence of fever should not reduce your suspicion of septic arthritis if the clinical presentation is suggestive of that. Coming to radiography findings, in case of your acute septic arthritis, because there is no much time for bone damage, general findings include soft tissue swelling, there will be joint space widening, and there will be displacement of tissue placed by the distended capsule. So because there is acute infection is there, so much inflammation is going on, so much leakage of plasma is there, all this will lead to effusion there, and effusion will lead to your soft tissue swelling, joint space widening, and there will be displacement of tissue plates. That happens in the acute setting. So what happens, supposing there is advanced stage in infection was there for so long time and nobody has treated it, then there can be narrowing the joint space and bone erosion. And this occurs because of damage to bone itself. USG, generally we do USG for the deeper joints, like we discussed in case of hip, in case of shoulder, these are bigger joints and they're covered with big muscles. So we cannot palpate them for effusion. Generally, we use USG to look for presence of any effusion in these joints. Then in case of sacroiliac joint or sternoclavicular joint or the spine, it means the axial system. You can do CT or MRI to look for presence of any bone pathologies because of the infection or because or soft tissue collection infection. Everything can be seen with the help of MRI. Lab findings. So whenever a patient is presented to you with possible septic arthritis, it is always good to collect blood before antibiotic therapy if possible. If it is not possible, you should not delay your antibiotic therapy because rapid treatment, early treatment is the best for the patient. So blood culture, if you collect, then in case of Staph aureus, you will find a blood culture positivity in 50 to 70% of cases. But the rate is less frequent for others, probably because it is difficult to grow them in a simple medium. Then if you will see the synovial fluid, as we discussed, it will be turbid because it will have lots of cells and protein will be there. It can be serosanguinous also, or it can be frankly purulent. If the WBC count is more than 50,000 to 75,000 or more than 1 lakh, in such cases, your synovial fluid will be frankly purulent. Gram stain. So in gram stain itself, you can see large number of neutrophils. If you are lucky enough, you can see some organisms. So as we discussed already, total protein, LDH, and glucose, there are changes in these parameters. Protein can be very high, LDH can be very high, glucose can be very low. But because these findings are not standardized in case of synovial fluid, and there are multiple causes of these findings, that's why these tests are not recommended, not to be done in synovial fluid. As we discussed earlier, always look for crystals because clinically you cannot differentiate between acute crystal arthropathy and septic arthritis. Both can have fever, both can have tender swollen joint, and both can have very high WBC count. In fact, in many cases of crystal arthropathy, when we seek out patients, there will be a hidden infection also. So always look for crystals or vice versa. Then if you go for this smear positivity, you can see 75% of people with Staph aureus and streptococci, they can show on smear itself the presence of organism. And in gram-negative bacteria, another bacteria, the rate is 50%. And then culture you should do. Culture generally is positive in more than 90% of cases, except gonococcal patients. And in some cases, like when suspecting gonococci or the first phase, in those cases, you can go with the nucleic acid amplification based assays for bacterial DNA. So all these tests can be done in case of septic arthritis. As far as treatment is concerned, so treatment will depend on what have you found on your smear or culture. So if suppose your gram stain is showing gram positive cocci mostly treated most commonly with vancomycin that is given 30 mg per kg daily IV into 20 doses, and those generally should not exceed more than 2 gram per day. If vancomycin is not available or allergy is there, then you can go with clindamycin that is given IV 600 mg every 8 hours, or we can give oral 300 to 40 mg 4 times daily, 600 mg 3 times daily. If suppose your gram stain is showing presence of gram negative baseline, then you can go either with ceftazidime You can go with ceftriaxone, you can go with cefotaxime, or you can go with and these all can be used. And ceftriaxone should be combined with an aminoglycoside such as gentamicin or other drugs if you are considering Pseudomonas aeruginosa as a likely pathogen. For example, in IV drug abusers, Pseudomonas is very common. So in those cases, you can combine ceftriaxone with one aminoglycoside. Or suppose if there is allergies to cephalosporin group of drugs, then you can treat this patient with help of Ciplox. But generally, what happens when we take a patient of septic arthritis on a ward in our clinic and we see when the results of gram stain is not available? In such cases, generally we start patient on empirical antibiotic therapy. So most commonly what we do, we start patient on ceftriaxone plus vancomycin to cover both gram positive and gram negative. Once the results of culture are available or the result of gram stains are available, then we can provide more specific antibiotic therapy. Suppose if gonococcal arthritis is suspected, then either you can go with ceftriaxone or gentamicin or gemifloxacin if gonococcal arthritis is suspected. So total duration therapy is 4 to 6 weeks. So what we do, preferably, we start our patient with IV antibiotics. Once after starting antibiotic, fever is not there, counts are improving, joint is improving. Then after 2 weeks, we generally change to oral route and we try to continue that therapy for more 2 to 4 weeks. So total therapy is for 4 to 6 weeks. And as soon as these culture reports are there, we can provide specific antibiotic. Otherwise, generally we start patient on this presumptive antibiotic therapy. And apart from treating the infection, you have to also maintain the normal function of the joint. So what we do, we try to maintain that joint functional position. Mostly it is in slight flexion that provides the maximum space in joint with minimum pressure. And we also start once passive exercise and followed by active exercise once the pain is reduced, the joint. Suppose if after doing all this antibiotic and everything, there's no improvement in the joint, or there is suspicion of collection of abscess in joint. In such cases, joint drainage is required because that if that abscess is collected, they're not cleared off, then joint will not improve. And arthrotomy may be required. Mostly this happened in case of hip when there is a septic arthritis of hip, especially in children. Then in those cases, arthrotomy may be required. So if medical therapy is not sufficient, then you have to go with your surgical intervention. Coming to gonococcal arthritis, as we already discussed, gonococcal arthritis, most common cause of septic arthritis in young adolescents and adults because of sexual behavior. So nowadays there is decline in the incidence of gonococcal arthritis. Earlier there were like 70% of cases of infectious arthritis less than 40 years of age were because of gonococci only, but nowadays the rate has reduced. And pathology is simple. There will be bacteremia because of some colonization or some infection in the body, mostly urethral infection, cervical infection, or let's say phalangeal infection will be there by gonococci. And once that infection or colonization there, if by any reason there is bacteremia, it reaches to joint, and once it reaches to joint, and then it lead to infection. So this is the pathology of gonococcal arthritis. So there are some risk factors for disseminated gonococcal infection. We'll discuss what DGI is in some time. So there are some risk factors. Some host-dependent risk factors include women. In case of women, the rate is as much as 2 to 3 times higher compared to men, and they are specifically prone to get this infection when they're having menstruation or when they're pregnant. Also, there's if the complement deficiency, like late complement deficiency is there, then in these cases there can be recurrent infection of disseminated gonococcal infection. We know complement system is required to clear out these encapsulated bacteria, and when complement deficiency is there, these bacteria cannot be cleared off. That's why they will have frequent relapses. There are some factors dependent on the pathogen itself. So those gonococci which form transparent culture colonies on the media, or who are having a type 1A outer membrane protein, or who are like AUH oxytroph type. So these AUH oxytroph types are like actually the one which are positive for urea hydrolysis. So if these things are there in microbes, these are the pathogens which are more prone to cause your disseminated gonococcal infection. So coming to how these patients will present. Now seeing this figure, there is a clinical spectrum. There is actually two kinds of forms. So one can be there's a form of disseminated gonococcal infection, or there can be a true septic arthritis form, or there can be overlap feature. So generally, patient either present with a disseminated gonococcal infection, or they can present with a true septic arthritis of the joint. So we will see what these are. So if we see this disseminated gonococcal infection, generally in this case there is not there is not a true infection of the joint. There will be just bacteremia, and there will be a reactionary infiltrate in your synovial fluid. So generally, these patients of disseminated gonococcal infection, they present with fever, chills, rash, and articular symptoms, and they will have skin lesions in less 70 to 75% of patients. Generally, they will have small macules or papules with an erythematous base, but these can actually modify and can turn into pustules, vesicles, bullae formation, or there can be erythematosus urticaria. Some papules can become hemorrhagic, and they can progress to hemorrhagic pustules, and generally they develop on trunk and external surface of distal extremities. And apart from that, there will be involvement of soft tissue in terms of tenosynovitis. So what happens in case of your DGI syndrome? Apart from having your joint pain, you will also have lots of edema and lots of swelling of soft tissue, that is tenosynovitis of the knee, hands, wrist, feet, and ankles. Arthritis in case of your DGI syndrome is like migratory. Pathology is simple. There is no true bacteria presence in the synovial fluid. It is a consequence of your immune reaction to circulating gonococci and immune complex deposition in tissue. So, what you can consider is like a reactive form of polyarthritis secondary to gonococcal infection. So, see this figure. So, this disseminated gonococcal infection is also known as arthritis dermatitis syndrome. So, what happens? There will be involvement of multiple joints like ankle, knee, and around the joint you will see lots of your skin findings. For example, you can see in this figure, if you see in this figure, there is swelling of ankle joint, and apart from that, on the skin, you can see the presence of multiple macule papules and some pustule is there. Similarly, you can see on the trunk there are some pustules, and you can see in this finger there is presence of one pustule. So what happens in patients of DGI, you will find the patient having presence of multiple migratory arthritis joints along with presence of periarticular skin findings. So this is why it is known as arthritis dermatitis syndrome. In lab findings, if you see, so generally because there is no bacteria in the joint itself, so obviously synovial fluid cultures will be negative. Blood culture can be still positive because they are having a true bacteremia. In half of the patient, there will be a positive blood culture. And because joints are having actually a secondary, let's say, reactionary infiltrate and inflammation, that's why fluid that is formed in joint is not much, and it can be difficult to excrete that fluid. And count, if you check in that fluid, will be not very high. It will be somewhere around 10,000 to 20,000 of leukocytes per ml of fluid. Now coming to true gonococcal septic arthritis. Now understand that. Suppose there is bacteremia in a patient of DGI. Because of bacteremia, there is a reactionary arthritis, polyarthritis. And what can happen in reality? One of the joints, or let's say few joints, can have a true infection. There can be barrier breach, and this bacteria can go into the joint and can cause a true infection. That is known as true gonococcal septic arthritis. So this is generally less common than DGI syndrome, and generally it almost always follow DGI. Somebody will have a disseminated gonococcal infection, and after that there will be a development of true septic arthritis in one or few other joints. Most commonly it is monoarticular form. Generally it involves hip, knee, ankle, or wrist. If you will check synovial fluid, because synovial fluid will be easy to obtain in these patients, there will be lots of reaction because of true infection. You will be able to aspirate that fluid, and if you send that fluid for analysis, you will find that count is very high, more than 50,000 counts of leukocytes per ml. And gram stain, if you do, it can be occasionally positive, but mind you that this bacteria is little fastidious, it requires special media, so culture may not be, or gram stain may not be positive. Synovial culture, if you see, the rate is 40% of cases. You remember in case of acute septic arthritis because of staph or strepto, we were seeing that the culture rate is more than 90%, but here the culture rate is less than 40% of cases. So blood cultures are almost always negative. So what is the point? Point is that generally when there is a DGI syndrome, bacteria is in the blood, bacterium is happening, and once that is settling down, then bacteria has gone to joint. That is why in case of DGI, if you do blood culture, it will be mostly positive. But when you patient has developed septic arthritis, blood will be negative, but joint will contain the bacteria. So this is a figure you can see. These all are these small thing that is present within cells are diplococci, and this is a gram stain of reflex rate in the patient of gonorrhea, and it's showing presence of these diplococci within the cells. So lab workup in case of true gonococcal arthritis. Generally, it is difficult to isolate gonococci from seminal fluid and blood. Specimen should be obtained from potentially infected mucosal site. And what we can do, we can also go with a nucleic acid amplification based urine test. And culture and gram stain smears of skin lesions can occasionally be positive. Generally, we are using thyromartin agar medium directly, or we can transport this swab in special transport media. So what they have told that this gonococci is carbon dioxide loving bacteria. So when they take the sample in the swab, they take a swab in specimen, then they place it in a jar with a candle so that 5% carbon dioxide can be provided. That kind of media is required for transfer. Then, because culture rate is less positive in case of our gonococcal arthritis, so in this scenario, it is best to utilize nucleic acid amplification based test treatment. So remember, gonococcal arthritis is happening because of sexual practices mostly. So you have to treat patient for gonococcal arthritis, that is done by providing ceftriaxone 1 gram IV or IM every 24 hours to cover possible penicillin-resistant organism. In most of the cases of gonococcal arthritis, there will be a co-infection by chlamydia that cannot be ruled out. So that is why we also cover for chlamydial infection. We provide erythromycin 1 gram oral stat dose as single dose to treat chlamydial infection. And remember to treat and test associated sexual partners. 7-day course generally required for treatment of gonococcal arthritis. If suppose there is a penicillin susceptibility, you can give amox 500 mg TDS daily, or suppose you can go with Ciplox 500 mg twice daily. In case of your subcutaneous arthritis, suppose if there is pus formation in joint, so what you need to do, you have to aspirate, you have to drain that joint, and after that you can provide therapy for 7 to 14 days of antibiotic treatment is required. This is how you treat patients of your disseminated gonococcal infection or true gonococcal arthritis. Coming to spirochetal arthritis, so spirochetal family basically it involves your syphilis is there, then your uh, Lyme is there. So these all are there, and generally syphilis and Lyme they present with recurrent arthritis. So coming to Lyme disease, so Lyme disease, arthritis is a common finding actually. If you don't treat patient, then up to 60% of untreated patients can show presence of your arthritis in one or other form. And when true infection occurs within days or weeks of inoculation of this thing because of your isodistic, there will be intermittent arthralgia and myalgias, but true arthritis will develop only in 60% of patients. So this is the isodistic, which is responsible for inoculation of your bacteria in the blood. Once your infection sets in, then you can have three different forms in which Lyme can present. So most common form is intermittent episodes of monoarthritis or oligoarthritis. So this is present in half of the untreated patients, and generally presents with the involvement of the larger joints. Mostly it is the knee, which is the most common joint, or other large joints like ankle or hip or shoulder can be involved. Symptoms can wax and wane. So symptoms can wax and wane. That's why I was telling that mostly these parochial infections they present with intermittent recurrent arthritis. And then if we don't treat them, 10 to 20% of patient will improve by themselves per year. Then 20% patient can present with non-specific arthralgia. And in these non-specific arthralgia also, their symptoms will wax and wane with time. These have slow indolent course, and then chronic inflammatory synovitis, there will be 10% of patients who can actually develop a destructive erosive lesions of these joints, which can lead to deforming arthritis in 10% of patients. This staph and diphtheroid, this is some mistake here. This is not a part of this part. Okay. So how we diagnose these patients? Generally, we can look for the presence of anti-Borrelia antibodies, IgG antibodies, and these are present in 90% of patients with Lyme arthritis. Or you can go with the nucleic acid amplification-based assay that is also present in mostly 85 to 90% of patients. So you can go with these tests when your Lyme is suspected. As far as treatment is concerned, we know it is easy to treat spirochetal infections. Either we can go with the doxycycline course, we can go with the amoxicillin course, or in case of allergies, we can go with cefuroxime, Exetil, or erythromycin. So what they have recommended in case of arthritis, either intermittent or persistent, you have to treat with oral regime for at least 1 to 2 months, or IV regime can be used for 2 to 4 weeks. So these drugs can be used to treat true infection as well as this arthritis because of your Borrelia burgdorferi. Coming to syphilitic arthritis, so syphilis, as we know, it is because of Treponema pallidum. Syphilis, once it was rampant, but now cases are less known. Now only seen case of coexisting HIV only. So it is caused by Treponema pallidum, and generally there will be episodes of active disease followed by asymptomatic period of latency. So this is the reason why also syphilis present with your recurrent arthritis. So you can divide your syphilis into two ways. So one way is you can divide it primary, secondary, tertiary, or the other way is you can divide it early and late syphilis. So primary syphilis occurs when there is primary inoculation. So after, let's say, once one sexual activity, or let's say one IV drug use, or let's say some needle injury, something happens. After that, you'll have primary inoculation. You will develop a hard chancre thing near your genitalia, and then it will be painless, and that it will improve by itself. And after 6 weeks to 6 months, you will develop secondary syphilis because of hematologic spread, because bacteria was not cleared off completely there. And then after years, there can be tertiary syphilis that most commonly either will be a neurosyphilis or cardiosyphilis. Or other way of dividing of syphilis is early syphilis or late syphilis. So this generally we see in terms of time of infection. Suppose any manifestation occurring within first year of infection, it is known as early syphilis, and then if it is after first year of infection, it is late syphilis. So in by that definition, mostly your primary syphilis and secondary syphilis will be part of early syphilis. So coming to uh, they manifest in different parts. So these musculoskeletal manifestation can be present in all the forms, congenital form as well, secondary, tertiary. Mostly in primary, these are not there. Then most commonly, these manifestations are present in secondary stage because there is hematologic spread. So once there is hematologic spread, there is development of non-specific arthritis and myalgias. Generally, this secondary syphilis starts 6 weeks to 6 months after of your primary syphilis, means primary inoculation. There can be presence of fever, myalgia, bone and joint pain. There can be some transaminitis, or there can be development of typical maculopapular rash over the body that is known as rosula syphilitica. So this table is actually summarizing all the features of syphilitic arthritis in different kind of forms. In case of your early congenital syphilis that presents within the with after birth, or with the birth, or let's say within few years of birth, in that case you can find either there can be periarticular swelling and immobilization of the involved limbs, that is known as Barrett's pseudoparalysis. There can be osteochondritis of the long bones, or there can be osteitis or periosteitis. This Wimberger sign, that is actually symmetric destruction of the medial aspect of proximal tibial metaphysis, is actually one of the pathognomonic finding of congenital syphilis, which is not seen anywhere else. Late congenital syphilis, generally 8 to 15 years of age, it develops, and in those cases, you can develop chronic painless synovitis with effusion of large joint, that is known as Clayton's joint. Particularly knee and elbow will be involved. So there will be swelling of these joints, painless swelling with loss of effusion, no pain, and these are known as Clayton's joint. In case of secondary syphilis that occurs because of hematologic spread, you can find arthralgia. There can be symmetric arthritis of the knee and ankles, and occasionally there will be involvement of other joints like shoulder, wrist, and sacroiliitis. In case of tertiary syphilis, as we know, because of the neuropathy, because there is the loss of sensation, there will be development of Charcot joint. In fact, the first case of Charcot joint was diagnosed in a patient of syphilis. Was a military man who was actually doing this march and was having total obliteration and damage of his ankle joint. Coming to diagnosis, how do you diagnose this patient of syphilis? So this is the common approach which is used. So what you do first, you do the test which is more sensitive. So in case of syphilis, this treponema, this TPPA test, that is treponema pallidum particle aggregate test, TPP test can be used. It is a pattern specific skin test. And suppose if this test comes positive, then we can confirm it by doing another test. So what we do, we use a different antigen, and we can do a ELISA test for identifying a different antigen of treponema pallidum. Then activity level generally is seen with the help of titers of antibodies. Most commonly, we use cardiolepin antibodies or trypanospecific IgM antibodies, and we see whether the disease is active or there is a residual seropositivity in inactive diseases. So these antibody levels can be followed up, can be used to follow the patients. Apart from these tests, we can have other new tests for diagnosis. It includes immunochromatography strip test or Western blot analysis for the protein of Treponema bacteria, or we can go with a nucleic acid amplification test. So these tests can be used to diagnose your syphilis. As far as treatment is concerned, so treatment depends on the stage, early syphilis, late syphilis, or there is an alternative treatment when there is an allergy. So in case of early syphilis, benzathine penicillin single shot of 2.4 million units is given. Generally, it is given in the divided form. 1.2 million is given in one buttock and 1.2 million in other buttock, and that's how we treat it. In late syphilis, you have to provide 3 injections. You would provide one injection today, then after 1 week, and then after 2 weeks. So, but thing is, if you see, the failure rate is up to 20% in early syphilis and it is 30% in late syphilis. So, this is the reason you should actually follow these patients for the relapse of the disease, or you can follow them with the help of antibodies to look for complete treatment of these patients. Suppose if there is allergy to penicillin in this patient, then you can go with the either doxycycline 100 GPD regime for 2 weeks, or you can provide ceftriaxone 1 gram or 2 gram per day for 10 days. So this is how you treat syphilis. All patients need rigorous clinical and blood workup follow-up every 3 months for a year at least. And whenever you diagnose anybody with syphilis, there's a quite possibility that you are dealing with coexistent other STDs, including gonorrhea and HIV. So all the patients who are presented to you with syphilis, you should check for HIV and other STDs as well. Coming to Mycobacterial arthritis, as we know, is because of Mycobacterial tuberculosis. So generally, patients of TB, generally they don't present with any kind of arthritis, but in some cases you will find coexisting arthritis as well. So if you see, tubercular arthritis overall generally represents only 1% of all TB cases. Most common form, as we know, is pulmonary, and even in extrapulmonary cases, only 10%, one out of 10% will present with the musculoskeletal TB. Types of presentation, there can be most common presentation in case of arthritis. Now we are not covering here your TB spine. TB spine is out of syllabus of this chapter, but the TB spine is the most common way through which musculoskeletal tuberculosis presents. As well as arthritis is concerned, there are two different presentations. In arthritis, most common presentation is chronic granulomatous monoarthritis. It means one single, slow, indolent infection of one joint will be there. Mostly it is knee or hip. The other form is Ponce's disease. So Ponce's disease is nothing but Ponce's disease is like a reactive arthritis only, second to tuberculosis. So what happened? There will be reactive symmetric polyarthritis in patient with having visceral or disseminated tuberculosis. You should also remember that patients of these bladder cancer, they are being provided BCG, intravesical BCG therapy. Even in those patients, some patient will develop this reactive form of arthritis. But Ponce disease is term reserved for presence of symmetric polyarthritis reactive type when patient have infection elsewhere in the body. So clinical features generally most commonly large weight bearing joints are involved, most commonly either hip, knee or ankle. Sometimes there can be involvement to small non-weight bearing joints. And in general, the course is very slow but progressive. It is indolent. Generally, there will be monoarticular swelling and pain that will be there for like months or years. And systemic symptoms may or may not be present. Half of the patient may have these symptoms. And it generally occurs as a part of disseminated primary infection or through late reactivation. This late reactivation thing is commonly seen in case of HIV and immunocompromised host. So we, in our clinical practice, I have seen like 3-4 patients of SLE, like who were on treatment for so long time. And after 3-4 years of treatment, and then they presented with the tuberculosis, TB of ankle, let's say TB of wrist, that kind of cases we have seen in our practice. And in general, these patients will not be having a coexistent active pulmonary tuberculosis. This might be the reason why we tend to miss tuberculosis as one GDs when patient present with these symptoms. In lab findings, if generally we don't aspirate the joint, but if joints are aspirable, then count is not very high. 20,000 count will be there roughly, and roughly there will be 50% neutrophils, and rest will be lymphocytes. AFB positivity can be seen on that smear of that fluid in 30% of cases. Fluid culture positivity is very high, around 80%. And if you take this animal tissue biopsy culture, then 90% will be positive. So many cases can present like with chronic monoarthritis, and when we do biopsy, the only thing we find there is non-specific inflammation. But if we send this tissue for the culture, then mostly culture will be positive. So our practice is that whenever one patient is presented to us with chronic monoarthritis, we tend to do for a biopsy as well. We tend to do we are going also for a culture of the biopsy tissue, especially for tuberculosis. If you do histopath of that tissue, you will find granular matter inflammation there. And apart from these things, you can simply send that fluid for your gene expert or other methods of nucleic acid amplification based methods. And these methods can give reporting in 1 or 2 days. The radiology findings, if we see the X-ray of these TB patient, we find these three findings, and these three findings together constitute femistel triad, peripheral erosion at the point of cellular attachment, periarticular osteopenia, and joint space narrowing. So this femistel triad is not pathognomonic, not specific for TB, but it has been described in TB only. So these three findings when together they represent this is known as femistel triad. So treatment as we know, in case of our extrapermeable tuberculosis, treatment is same as permeable tuberculosis, but in some scenario like your musculoskeletal TB or your CNS TB, the duration is high. So in case of your arthritis, you provide same ATT therapy for longer time, 6 to 9 months. And in patients who are like on immunosuppressive therapy, like steroid or MMR or something like that, or patient having coexisting HIV, the response to therapy can be slow and therapy may be more prolonged. Depending on clinical response, we can decide when to stop therapy. So this is how you treat your TB arthritis. Coming to Ponce disease, as we discussed already, this is a kind of reactive arthritis. So this is characterized by non-erosive, non-deforming polyarthritis. It is generally associated with EPTB, extrapermeable TB somewhere in the body. And when you see joint, there will be no evidence of that joint involvement. That is why it is a reactive arthritis. So this is because molecular mimicry leading to Th1 mediated response in the joints. And generally, it is more common in your young people and slightly more common in women. Generally, these patients of Ponce disease, they present with fever, malaise. There can be polyarthritis, mostly large joints such as knee, ankles, and time wrist. Although book is telling about your large joints, but in our clinical practice, we have seen that many patients also present with development of small hand joints, and sometimes they like tend to mimic like our representation. Because these patients are having a true EPTB, extrapermeable TB somewhere, if you do a tuberculin test, mostly it will be positive, suggestive of that there is a reactive response to TB antigens. And in case of extrapermeable TB, also it is the lymph node disease, which is the most common with which Ponce disease is associated. So how do you treat it? Ponce disease, it beautifully responds to your ATD therapy, and for your symptomatic management, you can provide NSAIDs to these patients. So this is how you treat Ponce disease. I have seen like 2 cases of Ponce disease. In both the cases, as soon as we started ATD therapy, after let's say 2 to 3 weeks of therapy, their symptoms start resolving. Coming to atypical mycobacterial arthritis, now realize this typical mycobacteria goes for the bone, a typical mycobacteria goes for the soft tissue. Maybe a typical mycobacteria is not as strong that it can dissolve bones, that will be the reason. But mostly uh, they present with the soft tissue infection, but chronic indolent arthritis has been reported with them. And generally, in case of atypical mycobacteria, there will be history of some trauma or there will be history of some direct inoculation, like somebody doing farming, gardening, or aquatic activities. As we know, all these atypical mycobacteria, they are present in the environment. So they can, that's how they can get entry into joint. And in case of our HI patient, they can be hematogenous spread. And in smaller joints, digits, wrist, and knees are commonly involved. Apart from this joint involvement, there will be soft tissue involvement in terms of involvement of tendon sheaths and bursa, and this is typical of your atypical mycobacterial infection. So suppose if you are getting slow indolent monoarthritis with lots of soft tissue swelling, with lots of bursitis or let's say trypanoitis, then you should think about atypical mycobacteria as well, specifically in cases of HIV and other diseases. Most common pathogens which are associated with this condition include Mycobacterium marinum, Mycobacterium avium intracellularare, Mycobacterium terri, Kansai, Fortichum, and Chiloni. So all these are, or everything have been found. Apart from these, other things are also been found in case of atypical mycobacteria arthritis. So generally, how you diagnose them? You do a biopsy, you do culture, and culture will determine your antimicrobial susceptibility patterns. On the basis of that susceptibility, you plan your treatment for these patients. Coming to brucellosis, so brucellosis is one of the causes of pyrexia of unknown origin. When we were MD students, we used to screen for brucellosis as well. When patient used to come to us for pyrexia of unknown origin. But apart from fever, brucellosis can also present with musculoskeletal manifestation. In general, you can divide brucellosis into three kinds of presentation. Acute presentation is seen in 40% of patient, and generally patient present within 3 months of your inoculation of your bacteria. Subacute presentation is more common. Subacute presentation is from 3 months to 1 year, and after 1 year, it is chronic presentation. So acute stage, when brucellosis is there, they generally present with fatigue, fever, anorexia, nausea, and diarrhea. Brucellosis, as we know, is generally because of it is a zoonotic disease. Basically, it spreads from infection from animals. There will be cattle, and there will be infection in passes through either infected milk or handling of these animals. Actually, in outer Western countries, people were handling animals like veterans, farmers. In those populations, disease is endemic. In acute stage, fatigue, fever, anorexia, nausea, and diarrhea. In case of subacute stage, mostly they present with weight loss and palpitation, and it is a chronic stage which presents with osteoarticular manifestation. So let's see what are the osteoarticular manifestation of these brucellosis patients. So most commonly, these patients will have presence of axial symptoms. So they will have sacroiliitis in half of the patient. Then they can have peripheral arthritis, spondylitis. They can have osteomyelitis, bursitis, and in some cases there can be rheumatoid arthritis. So chronic brucellosis can present with musculoskeletal manifestation. Diagnosis simple. We can go with the presence of anti-brucellosis antibody, doing one early test, and we can see titers. If titer is more than 1 to 160, then we consider is like diagnostic in the background of typical clinical findings. The problem with titer thing is that titer can stay positive for longer times, as far as 18 months, and this is the reason why you cannot follow these patients. So even if you treat this patient, their titer can remain positive for longer times. You don't know whether that bacteria has been cleared off or not. Okay, blood culture generally will be positive, 50 to 80% of patient, even if patient is not having fever. So whenever brucellosis is suspected, you can go with the agglutination test, or you can go with the blood culture of these patients. So treatment, WHO has given two different treatment regime, and these two treatment regime is used for acute as well as chronic brucellosis. Either you can go with the doxycycline 100 mg BD for 45 days plus rifampicin 9 mg per day for 45 days, or what you can do, you can go with the doxycycline 100 mg BD for 45 days, and you can add streptomycin IE of 1 gram daily for 2 weeks. So both of these regimes are equally effective. You can use either of them. Coming to fungal arthritis. So fungal arthritis as such is unusual cause of chronic monoarticular arthritis, because fungus, they are like fastidious, and once the only way they can present is either they direct inoculation or the patient is highly immunosuppressed. So granular buttous arterial infection can be seen with some endemic dimer fungi. So these fungi, they are endemic actually in areas of Americas and South Americas. So coccidioides immitis, blastomyces dermatitis, histoplasma capsulatum. So these are the causes, some causes of granular buttous monoarticular chronic arthritis. Then there can be hematite seeding or diet extension. Mostly it is diet extension in case of your immunocompetent patients. But in case of your immunosuppressed patient, like HIV patient, there can be hematite seeding also. And sporotrichosis caused by Sporothic shinkii, as we know, this is most commonly seen in gardeners. There can be pricking injury because of thorns of that, and then there can be inoculation of these fungi. So mostly hands can be involved. Candida infection, we all have seen cases of candida in our patients of ICU. So candida infection generally, when it happens in MSK system, usually it involves single joint, and usually it's a larger joint, either knee, hip, or shoulder. Causes, either there can be a history of surgical procedure of the joint, or there can be intratural injection. In case of your among critically ill patient like ICU patients, there can be hematite spread. Hematite spread can lead to infection. And in case of your IV drug users, because they are using those filthy needles and dirty needles, and that can lead to involvement of multiple sites like spine, sacroiliac joints, or other fibrocartilage joints. So, characteristic feature of a fungal infection is that generally it is a low incidence and occupation-related disease. So, we don't see so many cases of fungal arthritis. In my whole life, I have seen only one case. In that, too, some aspergillus grew. Then generally occurrence in tropical and subtropical areas, because subtropical area these fungi they flourishes very well. Generally they occur in immunocompromised host, and the course is subacute or chronic. And in most of the cases, there will be presence of some other foci, like pulmonary cutaneous will be there, and from there they can be hematogenous spread in case of immunocompromised patient. And for diagnosing somebody definitively with the fungal arthritis, you need to show that fungi was demonstrated either in tissue or the culture, that synovial fluid or synovial tissue. So this figure, as we can see, but fungal infection is not that common. But once it occurs, then it can lead to rapid damage to joint or the bones. So as we can see, you can see all the midfoot has gone, and you can see all this is all so big issues are there. This photo is from a patient who has developed histoplasma, and histoplasma fungi has led to development of these severe bone erosions in the patient with chronic arthritis. So this figure is from Harrison. So you can see this is a case of histoplasma capsulated in the left knee. So this patient had some history of intervention to the joint, and then after that, many years after, he developed some swelling. You can see some soft swelling is there. So this is nothing but reactive sinus proliferation, and you can see in this X-ray as well that there is loss of joint space. There is gestational osteopenia is there, and there is soft swelling also there. So generally, your fungal arthritis will present with an indolent course. Systemic symptoms may or may not be there. There may be a history of some kind of procedure, or some occupational related risk will be there, or patient be compromised. In such cases, you have to think about fungal cause. Okay, so how do you manage these patients? Simple. When you even if you go for aspiration, count will not be very high. Count can be from 10,000 to 40,000 per ml, and most of the cells are neutrophils. Then you can use standard specimens, and you can send this that for culture, as well as you can take cell biopsy and you can send to culture. As far as treatment is concerned, if joint is full, there is aspiration, there is turbid fluid, then you can go with drainage and lavage the joint. And there is requirement of systemic administration of antifungal agents. So most commonly, we treat our patient with M4B or voriconazole intracontinental, depending on the pathogen. Then some centers they also use intra-articular installation efforts in B in addition to IV therapy, but the efficacy of this intervention has not been. Coming to viral arthritis. So viral arthritis, when we think, we remember about chikungunya, patients of dengue, let's say patients of measles, mumps, rubella, or there are hepatitis B, hepatitis C, and HIV. All of these can present with your arthritis manifestations as well. So coming to rubella, so rubella generally is not common because we know there is vaccine for that thing. But even after providing weak vaccine, what can happen? There can be a viral fever-like reaction. So there can be development of uh, in case of rubella, as such, when infection occurs within 3 days of rash, people can develop polyarticular pain. Or in case of live vaccine, that pain is seen most commonly after 2 to 6 weeks of vaccine introduction. So in case of women, there can be persistent arthritis in 50% of cases. 10% of rubella cases can develop frank arthritis, and there can be episodes of symmetric inflammation of fingers, wrist, and knee, and that can be there for as long as 1 year. Rarely, they can develop on syndrome, chronic fatigue, low grade fever, headache, and myalgia, and it can also persist for months or years. Coming to mumps, as we know, it generally involves your parotid glands and swelling will be there. In some cases, there can be self-limited monoarticular magnetic polyarthritis, and if these symptoms has to develop, they will develop within 2 weeks of the arthritis of mumps. And rubella was more common in females, but mumps arthritis is more common in males. In males, coming to parvovirus B19 infection. So this is one infection that you should know. So generally, what happens? Parvovirus B19 infection, parvovirus B19 virus actually loves kids. So what happens? Most of the kids they will get infected in their childhood only, and by the adult age, most of us will be having IgG antibodies against parvovirus B19. So understand this, that most adults will not develop infection because of parvovirus B19. If some adults are developing infection, there can be two reasons. Either they are really, really immunosuppressed, or they have frequent contact with children, like school teachers, nursery teachers, or let's say these hostel staff or something like that. So these will be the people who can have infection with parvovirus B19. So generally, Parvus B19 it is an erythrocyte precursor, and it actually uses blood group B antigen, that is globocyte GB4, to enter it. That is why this is specifically going and binding and staying with the your RBC precursors. So infection occurs generally in outbreaks, and it transmitted by respiratory secretion, and generally late winter and spring time, and it is occurring. IgG antibodies, as I discussed, is present in more than 90% of older adults. And the people who are at risk are children handlers, like school teachers, daycare workers, pediatric nurses. And once infection occurs to somebody, then household transmission rate is 50%. So suppose if a family has 6 people, 3 can get infected. So if we see clinical manifestation, we used to read that list of 6, 7 diseases. So among those diseases, the fifth disease is caused by infectious. Fifth disease is caused by your parvovirus B19. And generally, children when they will have this infection, they will have fever along with slap cheek appearance, and maculopapular or reticular rash can be there. The slap cheek is on the face, and the maculopapular rash can be on the back, on the buttock. When pregnancy it is affecting pregnant ladies, then it can lead to fetal hydrops because of destruction of all RBCs. In case of adults, it can present with transient aplastic crisis with chronic anemia in case of immunocompromised patients. So many of our patients of, let's say, SLE, we have seen that they were suffering from parvovirus B19 and they were having aplastic crisis. So coming to rheumatic manifestation of parvovirus B19. So articular manifestation, as we discussed, they are not found in children. They are most prominent in the early stage, and they are prominent in adults. So generally, when these features are there, features like RA-like features are there. So additive inflammatory arthritis will be there, RA-like, with prominent morning stiffness. But there will be minimal synovitis, and generally effusion will not be there. Frank joint effusion will not be there. And because there will be so much antibody formation when parvovirus infection is there, there can be formation of multiple types of autoantibodies like RF, ANA, anti-dsDNA, and other anti-ENAs and Apple antibodies. So all these will be forming. So what can happen? There can be false positive for RF, false positivity for ANA, and even anti-DHD also in these patients. And suppose if some patient present to you with present cytopenia because of transient aplastic crisis, there is presence of ANA, RF, or anti-DHD antibody and this arthritis, then surely this parvovirus B19 infection can present like a SLE mimic. So this is important for us when we diagnose our patient with SLE. We have to think about some common viral illnesses, including parvovirus B19. As far as management is concerned, so we know that IgG antibodies are present in more than 90% of people. So there is no point of screening for these antibodies. So we screen for specific IgM antibodies without presence of IgG anti-B19. If symptoms are there, this IgM antibodies are positive, mostly we are dealing with the case of your parvovirus B19. Symptom is supportive. There is no definite therapy for this thing because most of the cases infection will be cleared up by itself. Coming to hepatitis B associated arthritis. So hepatitis B virus associated rheumatoid manifestation has a huge list, but I am discussing only here hepatitis B associated arthritis. So there are 4 different forms of arthritis that can be seen associated with hepatitis B. So one thing is acute arthritis. So this acute arthritis can be because of acute infection when there is inoculation of this hepatitis B, or sometimes what can be there that we know that polyarthritis nodosa is associated with your hepatitis B. So either it can be part of PAN syndrome, or apart from that, there can be arthritis urticaria syndrome. So what happens when somebody has this hepatitis B in acute stage? 2 weeks before jaundice development, there can be immune complex mediated serum sickness-like reaction leading to your fever, your urticaria, your rash, and there can be symmetric arthalgia. So this is known as arthritis urticaria syndrome. It can be seen in as much as 10% of people. Apart from that, there can be symmetric polyarthritis, which actually resembles like RA with low complements and may be associated with skin rash, fever, or myalgia. Or apart from these things, there can be a true coexisting arthropathy in chronic hepatitis B virus. So any patient of HBV associated arthritis, HBV, any patient of hepatitis B presenting to you, think about whether it is related to hepatitis B, if it is related in what stage it is, or whether it is unrelated to hepatitis B. Coming to hepatitis C related arthritis, hepatitis C patients can have arthritis in four different forms. Either there can be a hepatitis C virus infection and coexisting arthropathy, or there can be a true hepatitis C virus associated arthritis, or there can be hepatitis C virus associated vasculitis associated arthritis, or there can be arthritis secondary to interferon therapy. So earlier when they used to give interferon, there used to be so much fever and joint pain and bone pain and body pain. Nowadays, people are not using interferon for hepatitis C, but interferon was also a common cause of arthritis in these patients. Coming to now, we see either we can have a coexisting arthropathy because of some other reason, or we can have a true associated arthritis, or we can have a cryoglomerular vasculitis. In this case, arthritis is a part of vasculitis, or there can be drug-induced arthritis. So when we see about true HCV associated arthritis, it can be of two types. So one can be RA-like polyarticular form. So, but this is not right. So there are so many features which will help you differentiate this hepatitis C virus associated arthritis from RA arthritis. So there will be same joint distribution as in RA, but there will be some features which are different. So let's say what difference is there. So hepatitis C virus associated arthritis is generally relatively benign cause. There will be no deformity in the joint. There will be no associated joint dissection, periatrial osteopenia, artery erosions. ESR will be elevated only in half of the patient. Fever or anemia, which is commonly seen in case of your RA, will not be there. Subcutaneous RA nodules, which are the features of RA, will not be here. Then RF positivity can be same. So RF positivity in general in RA is 40 to 70%, and that 40% to 70% hepatitis C can also have RF positivity. RF is relatively less specific for your RA. But ACPA, it is little specific for your RA. So ACPA positivity is less in your HCV associated arthritis. So all these features, when they're present, then it favors arthritis as part of hepatitis C rather than RA. Or what can be there if there is no this one way is that there can be a polyarticular presentation like RA, or there can be a mono to oligo-articular presentation. So true hepatitis C virus associated arthritis can present in these two different forms. Coming to alpha virus related arthritis. So now all these viruses are actually arthropod-borne viruses. So this fever caused by mosquito bite and then having musculoskeletal symptoms. So different regions, geographical regions have different viruses and they have different names. So we can see in this table, this is like name of the alpha virus, then geographic area, then the manifestation. So these are Ross River virus, Syphilis virus, Marrow virus, Onyongyong virus, Igbo Ora virus, and Chikungunya virus. So Chikungunya virus we will discuss further because we have chikungunya cases, we have seen them, and it is important for us. So chikungunya virus transmission, we can see that there are two different cycles. So one is urban cycle, one is sylvatic cycle. So generally, this virus is present in your forest area. Generally, these apes, langur, and all other these primates are there. Generally, virus is transmitted via mosquito to these things, and then again mosquito can bite and can get that virus. So this is known as sylvatic cycle. So what happens when somehow accidentally or by an incident, these mosquito we come into contact with these mosquitoes, then they can bite us. We can have a virus. It proliferates inside. Then again, mosquito will bite, and then again there will be transmission of virus from human to mosquito. Mosquito can again bite to some other human. So these are two kinds of transmission cycles. So one is urban, that is because of Aedes aegypti and albopictus. These are names of those mosquitoes which are included in urban cycles. Otherwise, in sylvatic cycle, Aedes africanus and Neo africanus are the mosquitoes involved. So there are three kinds of strain of chikungunya. One is West African strain, one is East Central South African strain, and one is Asian strain. And the beauty of this infection is that it has autochthonous transmission. Autochthonous transmission means mosquito bites to human, infection, human is again bited by mosquito and bites other human, then an infection. So this is the reason why there are so many cases. So coming to pathogenesis, So now realize what happens whenever there is this mosquito bites somebody, this inoculation of this virus. So virus goes inside your body. Once virus inside it goes, then it will infiltrate multiple tissues like liver, brain, joint, muscle, lymphoid tissue, skin, and soft tissue fibers. So what happens generally when these virus they have gone to the body and intercellularly, then NK cells, macrophages, these all are there and they will help killing these viruses. But there are multiple reasons because of which there is persistence of this virus into body. So thing is that the chikungunya virus is hypersensitive to interferon alpha. Thus it escapes. So whenever body cells are affected by any virus, there is production of interferon alpha by natural killer cells and macrophages, and generally this interferon alpha will kill your virus. But our chikungunya virus is hypersensitive to this effect, and that's how it escapes that killing. Other thing is what they're telling that interferon alpha is cytokine. For its working, you need to have proper temperature. So in case of joints, one hypothesis is that because the temperature of periphery joints is lower, so probably because of that interferon can't work efficiently. Then NK cell function has been found impaired and neutrophils generally absent in your central fluid. So all these are reasons that can lead to persistence of infection. Otherwise, in general, all virus infections are rapidly cleared of the body. So this is sequence of events. So suppose mosquito bite occurred here, then viral load start increasing 2 to 4 days, and it will be high by second to third day. Because viral infection has occurred, body has a mechanism to respond to that by producing interferon alpha. Interferon alpha will be produced and increased, but because it is not effective, it will go down. And then what we can see, clinical presentation, generally acute disease present within 3 to 5 days of the mosquito bite. And then because this now antigen exposure has occurred, the formation of antibodies by B cells, and there will be priming of T cells for long-term immunity. So long-term immunity, whether it is really there, we don't know because chikungunya reinfection is known. So that's why probably T cells they come down. And what can happen? There can be persistence of infection in many symptoms in many patients, and they can show relapse of disease symptoms in subsequent future. So coming to diagnosis, how to diagnose these patients with chikungunya? So WHO definition is that acute onset fever and joint pains, plus they should be a epidemic clue. It means either they should be residing in the endemic area or they should be a recent visit to endemic area, plus lab confirmation. So generally, what we generally go with antibodies, chikungunya anti-chikungunya antibodies. We can look for presence of IgM, or we can see fourfold rise in IgG titers. Or generally we are not using it clinically, but in experiment setting you can go with the RT-PCR. You can do RT-PCR within 3 to 4 days of 3 to 4 first days of illness, and that time you can find the viral uh, nucleic acid there. So in 2.5% of cases, there can be a concomitant dengue. So dengue and chikungunya can occur together. This is known as double bukhar, double viral fever. So when somebody is having concomitant dengue, at that time they will have severe muscular symptoms. They can have diarrhea, rash, and thrombocytopenia. This diarrhea, rash, and thrombocytopenia mostly because of concomitant dengue infection. Then in between, we also studied about Zika virus. So chikungunya infection, it has been seen in studies that it might increase severity of Zika virus infection through unknown mechanism. And suppose if somebody is having HIV chikungunya, then lymphopenia is more common. And when chikungunya is occurring in malaria, malaria actually ameliorates chikungunya virus arthropathy. So these are features when there is a coexisting other illness. So this chart has been given by expert committee. So how you go for your this thing diagnosis. So patient who are claimed suspected of dengue, chikungunya, Zika, or who have living in endemic area or travel history with simultaneous outbreak, sampling you can do. If sampling is done within less than 5 days, acute phase, less than 5 days of symptom absent, then what you can do, you can go with NS and ELISA or RT-PCR take. So if NS and ELISA is positive, then you can go for your dengue thingy. If suppose RT-PCR for Zika is positive, then possibly you are dealing with Zika, or there can be positivity for both. Here, what you are seeing for presence of IgM for dengue if your presentation is after 5 to 6 days of timing. So depending on what antibody has come positive, you can get to know what infection we are dealing with. So depending on timing of presentation, you can either look for antigen or antibody. different antigen, different antibody will help you to diagnose the condition, whether we are dealing with a case of isolated chikungunya, Zika, dengue, or there is a co-infection. So disease manifestation as we see, so generally in acute conditions there will be arthralgia, arthritis, mostly 80% people will be having this manifestation. There can be also involvement of periarticular tissue, enthesitis, tenosynovitis, bursitis can be there. And there can be development of a non-erosive arthropathy that involves same joint, which are affected during the acute phase. So this non-erosive arthropathy can develop in chronic term. Alopecia can be seen in one-third patient. Depression has been documented in up to half of the patients, and there can be in long-term fatigue, mood disorders, and sleep disorders. So this figure is important because this figure is showing what joints are involved with what frequency in overall red color, and the green color is showing presence of your data from India. So in acute chikungunya, if you see, it is the wrist joint which is most commonly involved in case of your acute chikungunya fever. So in India, the most common joint which is involved in acute chikungunya is your wrist joint. Similarly, they have shown that chronic arthritis can be there in multiple joints. So the message to be taken from this figure is that almost all the joints can be involved in both acute as well as chronic chikungunya. Second message is that in acute chikungunya, it's the most common joint involvement is your wrist and your elbow. Okay. So sometimes what can happen, there can be chikungunya or dengue confusion can be there because we know that these both we are endemic country for both of these infection. So in case of chikungunya, we see presentation. Then in case of chikungunya virus, if you see, generally rash is not a feature. It might or might not be there, but in dengue that rash is there. Arthralgia is generally severe in case of your dengue, but it is moderate in case of your this thing. Arthritis is very frequent in dengue, but not in chikungunya. Bone pains is very common in dengue, so much so that dengue is also known as haddi throat bukhar, that is breakbone fever. Thrombocytopenia generally not a feature of chikungunya; it's feature of dengue. Then hemorrhage is not seen in chikungunya; it is seen in case of dengue. Shock syndrome is also seen in dengue. And immunity, IgG, generally in case of chikungunya, it is lifelong, but dengue immunity is weak compared to chikungunya. There can be second attack with fatality because of second infection. So these are the features which clinically you can use to differentiate whether you are dealing with chikungunya and dengue. But remember, we discussed already that 2.5% of patients can have a combined infection of both of these viruses. So let's see chronic disease after chikungunya. Chronic disease generally will develop in 40% of people, and 0.3% at 1 year will have chronic erosive arthritis. So what are the predictors? Who are the patient who will develop chronic arthritis in chikungunya? So generally, suppose somebody is having severe acute stage symptoms in the beginning. They are the one who are prone to develop chronic arthritis. If somebody is having comorbidities like osteoarthritis or diabetes or let's say hypertension, all these patients are prone to develop chronic disease. Somebody is having advanced age more than 35 years, they are more prone to develop chronic arthritis. And people who will develop who will have a who had a concomitant dengue infection are also more prone to develop chronic arthritis. So as far as mother to child transmission is concerned, 50% risk is there if there is a acute viremia during birth, and 20% of these children may have long-term sequelae, including neurodevelopmental delay. And overall case fatality rate is 3%. Treatment when somebody is having peripartum this chikungunya infection with active viremia, then hyperimmune anti-chikungunya virus antibody can be given. If it is not available, try to delay delivery by providing tocolytic therapy. As far as treatment is concerned, we know for viral illnesses there are no specific treatments. We have conservative treatment. In acute phase, we can go with PCM we can give for initial treatment of fever and pain because we know that the risk of unknown dengue fever is there. So generally, if pain relief is adequate by PCM, we go with it. If it is inadequate, we can go with NSAID, but we have to use it caution because of either comorbidities or risk of dengue fever is there. In patients in whom joint pain is not taken care by your PCM or NSAID, then we can also consider these patients for low dose steroid. In chronic phase, generally sulfasalazine and methotrexate have been suggested as first line options. Suppose somebody has developed chronic arthritis, like picture in this chikungunya fever, we go with either sulfasalazine or methotrexate. And generally, these are considered when there is a destructive arthropathy. Suppose presence of erosion is there, or just osteopenia is there, or deformities are there, then we we do not hesitate to start these treatment. And when you're starting these DMARS, you have to regularly follow those patients. Generally, hydroxychloroquine should not be given to these patients. So this is one important message for you people. HCQ is given left and right for inflammatory arthritis, but what has been seen that in case of chronic chikungunya arthropathy, HCQ has been found to worsen disease. So mostly try to avoid HCQ in these patients. Coming to HIV-associated musculoskeletal presentations, now HIV is something that can involve any part of the body, uh, any possible way that is there. So it can mimic many conditions. So HIV, we have divided this manifestation of MSK system into four parts. So what can be there? There can be inflammatory bone and joint disease. There can be inflammatory muscle disease. There can be infective manifestations, or there can be miscellaneous manifestation. So let's see what are their inflammatory bone and joint manifestation. So HIV-associated arthralgia is something you should know. So this is generally self-limiting disease which occurs in 25% of patient, and the reason for that thing has been known as proxically cytokine or transient bone ischemia. And treatment generally we do with the help of non-narcotic analgesia, that is NSAIDs and assurance, because HIV-associated arthralgia will improve with time. And then coming to painful articular syndrome. So this painful articular syndrome generally present late stage of HIV, and it is also self-limiting, lasts for less than 24 hours. Most commonly it involves knee, and for this disease also we provide symptomatic treatment. Coming to HIV-associated arthritis, generally it is in 10 to 12% of people, and generally it involves lower limb joints, presents in oligoarticular fashion, and it is there for less than 6 weeks. Most commonly knee, ankles, and MTP joints are involved. If you do synovial fluid culture, it will be sterile, but if when we see under the electron microscope, we can see tubular reticular lesions. So these tubular reticular lesions are very specific for viral pathologies. So electron microscopy will show presence of these tubular reticular lesions in these patients. We treat these patients like inflammatory arthritis only. We provide low dose steroids, HCQ and SARS. SARS is pathology. Then there is reactive arthritis in HIV. So reactive arthritis in general and reactive arthritis in HIV is an important topic to understand, because there are so many features which are differentiating features. So see all these points. These points used to be favorite MCQs earlier. So reactive arthritis when happening in HIV, there will be less of axial involvement and less of uveitis. Peripheral arthritis will be more common and can be deforming. There will be more of skin involvement. So common subtype that can be seen in like psoriatic lesions, guttate, inverse, intradermic, they can be there, and more of enthesitis. Then they will have an aggressive course and poor prognosis. In general, we know that HLA-B27 delays progression of HIV, and HIV patients, they are more prone to allergy reaction to sulfur compounds. And treatment, you treat these patients with the help of NSAIDs. Most commonly, indomethacin is used. Sulfasalazine can be used. Methotrexate can be used. Some people have used retinoid like etritinib, and TNF inhibitor can be considered. Now, this is the important funda. We know that patients are already immunosuppressed, but if patient of HIV on ART therapy with controlled disease, no infection, and if CD4 count is more than 200 and a viral load is less than 60,000 copies, then these patients can be given cautiously biological agents. So it is not like that HIV is an absolute contraindication for biologicals. Okay. So psoriasis and psoriatic arthritis can also be seen there. So generally more of inverse guttate or epidermic subtype will be there, skin types. Then deforming arthritis can be there, less response to therapy. And treatment of psoriatic arthritis and treatment of your rheumatoid arthritis, generally it is same. Okay, and some patient can present it with undifferentiated SPA. It means they will not have full features. They will be presenting minor symptoms like isolated plantar fasciitis, Achilles tendinitis. So there can be these features like single features, and they might develop without any full-blown picture of SPA. So this can be taken as undifferentiated SPA in these patients. Then these patients can also have avascular necrosis of bone. Risk is 2 times than the general population, and generally risk is increased because of use of protease inhibitor as ART therapy. Alcohol intake, Apple antibodies can be there, IV drug abuse can be there, or HIV virus itself can lead to increase of AVN. Generally, clinical feature is pain on weight bearing, and apart from this, these patients can also have clubbing, that is hypertrophic pulmonary osteoarthropathy. seen commonly in association with PCP infection. When they can develop this Hopper picture, and it alleviates with treatment. Then osteopenia and osteoporosis can be there. Risk is 3 times higher, and generally treatment is like we do for general osteoporosis. Testosterone can also be added if testosterone levels are low. Then myalgia, HIV-associated myalgia, muscle disease we see. Myalgia is very common. To one-third of patients will have some non-specific myalgia. Fibromyalgia, that is generalized increased sensitivity to stimulus and causing pain, is seen in 10% of patients. Apart from that, there can be non-inflammatory necrotic myopathy. It is generally not known why it occurs, and we treat this non-inflammatory necrotic myopathy with the help of steroids. Then pneumonia myopathy. Pneumonia myopathy is generally occurring because of some genetic defect, but HIV associated as HIV patient can also show that kind of myopathy. Incidence is very rare, and the reason is G-band disruption in your actin myosin unit, and intracytoplasmic road bodies can be seen when you see under electron microscope, and that actually correspond to pneumonia rods. And it may be associated with monoclonal gammopathy. Treatment is generally with the help of steroid. If not being treated, then IVIG can be added. Coming to HIV-associated polymyositis and dermatomyositis. So HIV-associated polymyositis generally is more common. It occurs early in the course, and compared to idiopathic polymyositis form, it is occurring in younger patient, and there will be less elevation in creatine kinase enzyme. While polymyositis is more common in early form, dermatomyositis is more common in the late course of the disease, and it is less common. Coming to HIV-associated inclusion body myositis, similar to classic form, mitochondrial myopathy generally is because of zidovudine drug. Nowadays, we are not using zidovudine, but earlier we used to use it. And generally, it is associated with presence of red fibers. Treatment was simple: stop the drug, deal with recovery. Or there can be rhabdomyolysis. It can be HIV-associated itself, or can be drug-induced, or can be at the end stage. Miscellaneous condition that is seen in HIV is DILS. DILS, you should know, diffuse infiltrative lymphocytosis syndrome, most commonly in HLA-DR B1, 1101, 1301, 1302. So basically nothing. There is infiltration of tissue with CD8 positive, CD29 negative T cells are there. Pain generally present clinically with painless or painful peripheral swelling, and associated with lymphocytic intestinal pneumonitis or lymphocytic hepatitis. Treatment is simple. You provide steroid, ART, and symptomatic therapy. Then there can be vasculitis associated with HIV infection. Generally, there will be fusiform aneurysm formation in intracranial or extracardiac vessels. There can be formation of gangrene. There can be stroke, and vasculitis changes may not be seen. Then primary pulmonary hypertension can be seen either because of plasmodium pulmonary arteriopathy or thrombotic changes. Now coming to HIV-associated infective conditions of musculoskeletal system. So what we can see there, we can see pyomyositis, we can see bacterial arthritis, bacterial osteomyelitis, musculoskeletal TB, more common in HIV people, a typical mycobacterial infection, bacillary angiomatosis because of Bartonella Hensley, then fungal infection and parasitic infection. So all these can be seen there. Iris, you all have heard iris because many patients who are starting ART therapy, they can develop this uh, inflammatory feature. So basically, this highly active antiretroviral therapy related immune reconstitution inflammatory syndrome, IRIS syndrome, generally median time of presentation 9 months, and risk factor include if you are starting therapy of ART to somebody with a low CD4 count with concomitant infection, and you're treating HIV before treating infection, then there can be a IRIS-like feature. So criteria is there for IRIS, how you diagnose it. So like for diagnosis, you need to have HIV diagnosis in the background. There should be therapy should be started with CD4 count increasing and viral load decreasing. That means therapy is working, and inflammatory or infectious symptoms appear during course, and alternate causes are ruled out. If these all four features are there, then mostly we are taking the case of iris. So pathogenesis is simple. Early phase in first 6 months, there is release of memory CD4 cells, fever, malaise, weight loss. In late phase, it is basically because of release of nice CD4 cells and altered cytokine expression profile. Organic specific autoimmune manifestation can also develop in second phase. So like Graves' disease, terminalitis, GBS-like features, SLE, autoimmune hepatitis, acquired, all these things can develop. Treatment is simple. You just provide them steroid. You treat infection first and delay ART therapy till the resolution of infection. It will be over. Coming to HARP, that is HTLV1 associated arthropathy. So HTLV is like cousin brother of your HIV virus. So this disease is endemic in southern Japan and the Caribbean countries. So it presents like an inflammatory arthropathy which resembles RA. And viral transmission is like that HIV only, perinatal can be there, sexually can be there, or through contaminated blood transfusion can be there. So generally what happens, there is infection of these synovicites with HTLV and it leads to increased TNF alpha production. Arthropathy can develop. They can also have seropositivity for RF, symmetric arthropathy with inflammatory arthritis. If radiographs are done, they will show mild erosive changes, and treatment is like your RA only. You can provide NSAIDs, DMARDs, low-dose steroids, and if it's not being sufficient, then you can go with anti-TNF agents. Otherwise, illnesses that can be there, cell arthritis can be there, can be seen with rubella, Epstein-Barr virus, or Coxsackie virus. So coming to your parasitic arthritis, as such, parasitic arthritis is very, very uncommon, except in the setting of severe immunosuppression like HIV or some endemic regions. So these are some common parasites which have been seen in arthritis. So Dracunculus medinaceus has been seen to show destructive joint lesions in the lower extremities because those female they will migrate toward that thing and they will invert joints. There can be formation of ulcers in adjacent soft tissue and there can be secondary infection of those things. This Echinococcus granulosis, as we know, it causes hydatid disease. It can lead to formation of big cystic lesions. They can be expanding, destructive, and they can destroy the surrounding joint. Most commonly, it involves hip or pelvis. Then schistosomiasis can be there, one of the reasons of chronic synovitis, as schistosomal eggs have been found in synovial biopsies. Filariasis is common in our country. So there can be a monoarticular arthritis in children with lymphatic filariasis. So what happens? Many patients of lymphatic filariasis, specifically pediatric age group, they can present with a monoarticular presentation. Although there is no presence of this filaria in that synovial fluid, but this monoarticular arthritis secondary to filariasis will respond to diethyl carbamazepine. Then there can be presence of rheumatic second to hookworm, strongyloides, cryptosporidium, and giardia infections. So characteristic feature of parasitic rheumatism include there will be inflammatory arthropathy, there will be association with some residence in the local area, that endemic area or level to endemic area. There can be presence of eosinophilia, there can be absence of relief findings, there is no response to therapy as well. Parasite can be seen in the joint or surrounding tissue. And if you provide anti-parasitic medication, mostly that arthritis will respond. So this picture is showing presence of this is one your Escherichia lumbricoides, and we can see this is present in the tissue of SLE patient. SLE patient who presented with diffuse alveolar hemorrhage, and later on in that thing we found that tissue that they found that lumbricoides worm is there. Similarly, onchocerca volvulus has been seen in one of the shoulder tissue in one patient presented with chronic monoarticular arthritis. So all types of parasitic can be found in such kind of conditions. So this is a table which is showing presence of different parasites, their manifestation, and how do you treat them and what workup is required. This can be helpful for us. So coming to post-infectious arthritis. So post-infectious arthritis means reactive polyarthritis. Now understand this. So what happens? Once infection is there, some antigen is there, some antibodies forming against that antigen, then immune complexes are forming. These immune complexes they get deposited in different tissues. Let's say they deposit into vessels, they deposit into joints, they deposit into skin. So because of deposition of those immune complexes, multiple manifestation will occur. So reactive polyarthritis is nothing but it is an immune complex reaction towards an antigen of pathogen that is happening. So generally, in non-gonococcal arthritis, 1% of cases can have reactive polyarthritis after many weeks, or in case of enteric infection, 2% cases can develop reactive polyarthritis. Mostly it is seen with Yersinia ectocolytica, Shigella flexneri, Campylobacter jejuni, or Salmonella species. Apart from presence of this arthritis, less common manifestations of this reactive syndrome includes arthritis, conjunctivitis, uveitis, oral ulcers, and rash. So generally, when they have seen, there can be this is just a hypothesis because apart from chlamydia, they have not found any microbial DNA or antigen, but the pathogenesis postulate is that mostly because there is a persistence of microbial DNA or antigens in your feed that is leading to a picture of this reactive polyarthritis after so many weeks of the true infection. Clinical presentation most commonly generally it occurs among young men. And actually, B27 actually increase the risk of your reactive polyarthritis, mostly because of molecular mimicry. Then clinical features, generally they present with painful asymmetric oligoarthritis, mainly lower limb joint will be involved, including knee, ankles, feet, and sometimes there can be low back pain also. In long-standing disease, there can be development of sacroiliitis. Generally, most patients will recover within 6 months, but in some cases, there can be prolonged recurrent disease and is commonly seen in cases of chlamydia arthritis. Treatment, generally we give anti-inflammatory NSAIDs, they will be helpful. Antibiotic therapy, although recommended for chlamydia, but it is controversial at this stage. Then other way through which reactive polyarthritis can be there. One thing is acute rheumatic fever that is beyond of this sector, beyond the scope of this sector, and then post-streptococcal reactive arthritis (PSRA) is there. Generally, it is the close mimic of ARF. So generally, post-streptococcal reactive arthritis is not migratory. It lasts beyond typical 3-week maximum period of ARF, and it will respond poorly to aspirin. So all these 3 points can be helpful to differentiate PSRA from ARF. Coming to prosthetic joint infection. So prosthetic joint, basically what happens whenever there is a total joint damage, let's say there is total knee replacement we are done, total hip replacement we did. So there are two things. First thing is that there is presence of a metallic or presence of a foreign body in the foreign material in the body. Second thing is that there is a history of intervention, right? So all these two things are, all both these two things are actually responsible for increasing chance of infection. So generally, prevalence is 1 to 4%, 1 to 4%, but it is more common with the knee prosthesis. So 1% of for hip prosthesis and 2% for knee prosthesis. Risk factor for prosthetic joint infection includes older age, poor nutritional status, coexistence of joint disease, obesity, diabetes, malignancy, remote infection, and prior native joint infection. And if you are doing a prosthetic revision surgery or there is a contiguous superficial surgical site infection. So these all factors can increase the risk of infection to prosthetic joint. So generally, clinical presentation of prosthetic joint infection can be divided into three parts. There can be early infection, there can be late infection, there can be late infection. So suppose if somebody has the infection within 3 months of surgery, then it is known as early infection. And early infection generally presents with fever, pain, local sign of infection, and common causes which are there include Staph aureus, Streptococcus species, and granular bacilli. In delayed infection from 3 to 24 months, in this there will be slow intolerant course. This cause colonies, Coagulase negative staph is the one which is the most common cause of the infection. All diphtherids can be there. Late infection generally occurs 2 years after surgery, and it has nothing to do with surgery. And generally, it is by hematite spread, as in the known population, and it will also have an acute presentation. So basically, early infection, delayed infection, and late infection. So these three are there, and late infection has nothing to do with the surgery. Differentials. So when somebody is putting a prosthetic joint in the or prosthetic implant in the joint, so there can be either infection or there can be aseptic loosening of prosthesis. So what happens? They use cement and other material to fix that prosthesis. Sometimes what can happen? There can be a sterile reaction to that thing, and sterile reaction can lead to loosening of that prosthesis. So loosening can be there because of infection also, and because of your reaction, and because of infection also. So aseptic loosening of prosthesis is the most important differential that you have to think when you're dealing with a case of prosthetic infection. So generally what happens, infection is suspected strongly if at least one of the following features is present. So suppose if there is a growth of an identical organism in at least two culture of synovial fluid or prosthetic tissue. Suppose there is presence of purulent synovial fluid or presence of granulocytes on periprosthetic tissue, or suppose there is formation of sinus tract formation. So all these are actually favoring infection over aseptic loosening of prosthesis. Now remember, these radiography findings like presence of bone resorption, presence of severe radiolucency, presence of scalloping, presence of distal reaction, even fistula also. So what happens? All these features can also be found in your aseptic loosening of prosthesis and infection. The difference is that in case of infection, these features will be rapidly progressing, while in case of aseptic loosening, they will not be rapidly progressing. And these points are there which actually favor the infection over aseptic loosening of prosthesis. So how do you diagnose? We can go with a knee lateral joint. We can go for culture and ground stem. So when they are taking tissue, they can do sonication of explanted prosthetic material to improve the yield of culture. And we can use special media if you're thinking about first aid organisms. So synovial fluid precytosis with presence of polymorphs is actually a key finding when we are suspecting prosthetic joint infection. Treatment will have three different things. So one thing is surgery. So surgery can be done. So surgery, either you can implant same thing or you can implant some other new prosthesis. Even if you're planning both any of these things, reimplantation is generally differ by weeks to months, because if you do it early, then there are more chances of infection. Sometimes what can happen that because of infection, joint is so much damaged that you cannot reimplant the prosthesis. In such cases, there can be joint arthrodesis. Even in severe cases, amputation will be required. Prosthetic retention is generally thought of when there is no bone damage, there is no loosening, infection by strep or pneumococcal, which can be easily controlled. In such cases, prosthesis can be retained. In any case, antibiotic therapy has to be given. Generally, they combine oral rifampicin with other antibiotic. So rifampicin actually works better in case of these biofilm making bacteria over prosthesis. So this is the reason why rifampicin is being used along with other antibiotic. We can use quinolones, penicillin or vancomycin, and therapy is prolonged for 3 to 6 months with staphylococcal prostate joint infection. So surgical management can be of three types. Either there can be a debridement with prostate retention, one stage exchange, two stage exchange. So now realize, if I know that my joint is infected, prosthesis is there, my common sense say that I should not keep that prosthesis inside. It's a foreign body material, and if I'll keep it inside, no matter what, no matter how I treat it, my infection will not gonna be controlled. But there are certain scenarios when actually you can let that prosthesis there. So debridement with prosthesis treatment can be considered when all of these points are met. So suppose there is an early post-operative or acute hematologic infection. Duration is less than 3 weeks. Implant is stable. There is no tissue damage, and whatever organism that is growing is actually having. We have a good antibiotic against that. If all these features are met, then we can think about retention. Think about retaining that prosthesis in situ. If it is not there, then we can go with either one stage exchange and two stage exchange. So one stage exchange is done when, like, you open the patient, you take the prosthesis out, you put the new prosthesis. Or two stage exchange, what you do, you take the prosthesis out, you wait for some time, maybe few days or few weeks, and then you put the new fresh prosthesis. So one stage exchange is actually considered debridement, removal of all foreign material, the reinsertion of a new prosthesis, the same setting. It is generally done when all these are features are waiting, but the sign and symptoms persist for more than 3 weeks. In such condition, you can go for one stage exchange. So two-stage exchange is done in all the rest condition. Mostly if there is presence of resistant organism, presence of prosthesis loose, there is severe tissue damage, like from sinus tract, all these conditions you should actually consider for two-stage exchange. First, you remove the prosthesis, you treat the local infection, you wait for healing, and then when tissue is ready, then niche is ready, then you can put the new prosthesis that you can do. It is best to prevent infection in prosthetic joint than treating it. So we can have preoperative interventions, intraoperative intervention, and postoperative intervention. So in case of preoperative intervention, what you can do, like, you have to look for the risk factors which are there. Like patients of RA, they are prone to have infection. Previous surgery on the same joint has been done, they are prone to infection. Or if there is ongoing any kind of inflammatory therapy, then you have to look for how you can modify it. Like mostly for steroids, I'm telling about. So this is what you can do preoperatively. Intraoperatively, all patients should get antibiotic prophylaxis. Mostly they're giving cefazolin now, and you can use measures to decrease intraoperative contamination. Like nowadays in OTs, they have laminar flow system, so that there is no recycling of air and infection chances less. In case of postoperative, suppose if patient develop any kind of extraocular infection, let's say bed sore, UTI or pneumonia, you have to treat it promptly. Otherwise, there will be a hematinogenous spread to the prosthetic joint site. So now understand this thing. Prophylactic antibiotic therapy is not recommended before dental or urological procedures. So because now they have seen that this is a recommendation from that Association of Dentists and Association of Urologists, that when they have seen that bacteremia occurring after this procedure has not led to much significant increase in your prostate infection. So as if now there is no recommendation to provide prophylaxis antibiotic before these procedures if prosthetic joint surgery was done early in the patient. So this was a long discussion about all these causes. I hope that whatever questions we discussed in the beginning, you would have got answers to them. Although I have highlighted those answers, let's see. So first question was musculoskeletal manifestation of syphilis most commonly seen in. The answer was secondary syphilis. Like after 6 weeks to 6 months of primary syphilis, they will develop the myalgia, fever, arthralgia. So most commonly it is present in secondary syphilis. Then nursery class teacher, she is exposed to young kids. She's exposed to some flu-like illness. Mostly these children were having a parvovirus B19 outbreak. We know that parvovirus B19 can lead to fast positive ANA, fast positive RF, and antibody. So why we are taking parvovirus B19 here? Because history is very short and there are no other telltale sign of SLE. So mostly it is parvovirus B19. I hope I should not. I hope I don't need to explain you why we are not considering UCTT in our area. Then acute chikungunya fever. Now we know most common joint involved in India is wrist. This was MCQ in JIPMER Immunology in 2018 December session. This was the question which was asked in immunology entrance exam. Then a follow-up patient in ART clinic having severe reactive arthritis not being controlled with NSAIDs and sulfasalazine. Correct statement regarding further management. So HIV patient have high sulfur drug allergy, we discussed, and I told you that HIV status is not absolute contraindication for your not giving TNF inhibitor therapy. So if viral load and CD4 count should be checked before planning therapy. If viral load is less than 60,000 copy and CD4 count is more than 200, disease is controlled, there is no active infection, you are free to go with biological therapy in these patients. Then 40-year-old non-RA patient with history of right knee joint prosthesis 2 years ago, now plan for dental extraction. Then incorrect statements. Prosthetic joint infection always necessitates removal of prosthesis. No, now we have seen one stage exchange procedure and two-stage exchange procedure. We can also retain the prosthesis if particular conditions are fulfilled. Dental procedure predisposed to increased chance of prostate infection. It is not proven. That's why they are not recommending antibiotic therapy. So these two statements are. Thank you. Thank you for your patience to listen such a long discussion. I am open to suggestions and I am open to your queries if there are any.